Okay, we're going to begin. Next two slides, please. Today, we welcome you to the last of two of our 2016 SiNERGe CBO Collaborative webinar series, focusing on the very important issue of transitioning from adolescent to adult care. My name is Grace Bigelow, and I am the CBO Outreach Coordinator and will be moderating today's session. With these presentations, we are hoping to provide the most current information on topics of particular interest to the sickle cell community. We hope to target a lay audience, having the content be very accessible to all patients, family members, caregivers, and the wider sickle cell community. Of course, we always welcome suggestions from all of you on topics that you would like to learn about or people you'd particularly like to hear from. We are excited to continue our 2016 webinar series. We will continue with the theme, excuse me, Living Well with Sickle Cell, focusing today, as we did in our June session, on transitioning from adolescent to adult care. We are calling the series A Smooth Transition from Adolescent to Adult Sickle Cell Disease Care, Eliminating Barriers, Enhancing Resources, Part 1 and 2. We are very privileged today to have the highly esteemed Drs. Marcia Treadwell and Amy Sabota presenting first on some of the general issues and concerns during this crucial transition period, and then focusing more specifically on transition with sickle cell disease and some particular programs. We hope their presentations will both inform and inspire us, galvanizing all of us in our resolve to continue working towards improving the lives of those with sickle cell disease, as well as improving the relationships between those living with sickle cell disease, their families, and the healthcare system. The presentations will be followed by a hopefully robust question and answer period as time allows. We ask that you submit your questions in writing on your computer screen, and I will read as many questions as we have time for to the presenters for their response. Next slide, please. And now it is my pleasure to introduce our first speaker, Dr. Marcia Treadwell. Dr. Treadwell is a clinical psychologist and a clinical and health services researcher at the University of California, San Francisco, Benoff Children's Hospital, Oakland, in Oakland, California. Her research interests include cross-cultural models of health beliefs and practices, patient-reported outcomes, assessment and measurement development, transition from pediatric to adult care, adherence with medical regimens, and factors influencing pain experience. Dr. Treadwell is co-principal investigator for the Pacific Sickle Cell Regional Collaborative that aims to improve sickle cell disease clinical services and policy and enhance workforce development. Dr. Treadwell is co-investigator on exploring perspectives and genomics in the sickle cell public health interventions, an H3 Africa Consortium project. Dr. Treadwell obtained her PhD in clinical psychology from the University of Washington in Seattle and her training in clinical research from the Department of Epidemiology and Biostatistics of the University of California, San Francisco. Welcome, Dr. Treadwell.
Thank you, Grace. Thank you, everyone, for having me. Next slide. So, as Grace mentioned, this is the second in a two-part series, and Drs. Tepper and Hankins talked about transition in sickle cell disease in June. So with a quick review, I just wanted to remind you that they spoke about barriers to transition from pediatric to adult care that include insurance issues, limited access to knowledgeable adult providers, youth feeling unprepared or being poorly prepared to leave the pediatric program, the differing cultures of the worlds of pediatric and adult medicine. They also commented on the importance of assessing transition readiness and systematically addressing clinical, social, and educational challenges, remaining sensitive to the developmental tasks of adolescents. Finally, they gave helpful tools and measurement resources to assist in the process of transition, and these can be found at gottransition.org. Next slide. So my objectives building on that are to review contextual factors in the transition from pediatric to adult care for youth and young adults with sickle cell disease, and to talk with you about ethical issues in transition. Finally, I want to talk with you about additional considerations in designing transition programming that considers some of the specific unique aspects of sickle cell disease. Next slide. So this comes from the Devon and Telfair article in Pediatrics on transition to adult care for adolescents and young adults with sickle cell disease. And I am also a proponent of a model that is holistic, that one might call social ecological, with the youth and adolescent being the center of the picture as it is here, and the families as well in the center. Then you have to really look at and consider all of the entities that surround the youth and their families, whether it's the adult and pediatric provider, health insurance, but also issues related to education and employment, as well as other public supports that might be available. Next slide. I think that ethics in transition aren't often talked about. It's certainly part of what we do every day, but to really highlight some of the ethical issues, I wanted to talk first about the importance of preserving, promoting, and ensuring the dignity and respect for the patients. And many individuals with sickle cell disease, young adults, will express concern about moving into a world that they don't feel will be respectful of them. At the same time, the pediatric world needs to prepare the youth, and again, that's respectful, to have a youth that's very well prepared to navigate in the adult system. Another ethical issue is the importance of supporting trust in adult providers and in introducing a graduated system of transfer. So it really is most beneficial to the young person to encourage them to move into the adult world, but to make sure that they have the skills and the knowledge that they need to be successful in that world. Autonomy and self-management are, of course, important ethical principles, but autonomy can mean that the young adult will be completely independent, but autonomy and self-management must consider both the patient's and the family's values, their preferences, and the youth's capabilities. I'll be talking more about that a little bit later. Ethical issues of beneficence, that is promoting good, and non-maleficence, that is reducing harms, include providing care that is appropriate to the developmental level of the individual who is being transitioned. And finally, as providers, we have the duty to take on an advocacy role, because transition programs and practices still are suboptimal, not just for sickle cell, but for other conditions. Next slide. Given that, actually, let me pick up the phone because the Bay Area Rapid Transit goes by my window and I'm afraid you can't hear me. All right, so given thinking about ethical principles, then what are the pediatric provider's responsibilities? The pediatric provider needs to evaluate transition readiness goals and have as many interactions as needed until those goals are reached. Next, the pediatric provider needs to identify, along with the family, available and qualified adult care providers. And finally, it's the pediatric provider's responsibility to ensure that appropriate communication of the medical needs of the patient are given to the receiving provider. Next slide. So those responsibilities of the pediatric provider really incorporate elements of the patient-centered medical home. And the importance of the patient-centered medical home are recognized in the adult world as well. So the adult provider must ensure that the patient has good self-management skills and provide support through care coordination and consultation. Sensitivity and responsiveness responsiveness to the needs and challenges of young adults with sickle cell and transition are important. And again, I'll be getting in a little bit more detail about that shortly. Respect surfaces as well, that the values and autonomy are integrated, developed and supported for any individual person. And finally, that the adult and pediatric providers utilize a team approach. And the team includes not only the healthcare providers, but the public health system and the community-based resources. Next slide. In sickle cell disease, an important consideration is cognitive assessment. So we now know that up to 40% of adults who did not show previous neurological problems, in fact, end up evidencing problems with memory, with planning, or executive functioning. And so cognitive assessment is really critical, and Diane Wills set up a really excellent program incorporating cognitive assessment into the daily planning of transition for youth with sickle cell disease. And sometimes the youth and the family need to be supported in making a decision to understand that a given youth might not be able to become completely independent. And that needs to be an active and early decision that's made between the family and the youth, still respecting what the youth is capable of and the areas that they can be independent in. Pain is, of course, a hallmark of sickle cell disease, so there needs to be a written care plan for pain management. We've mentioned co-management, but that's extremely important. And finally, reviewing milestones annually. Next slide. So some of the medical milestones that need to be reviewed and that are outlined in the National Heart, Lung, and Blood Institute's guidelines for sickle cell care are in the areas of eye exams, dental, pulmonary function, and so on. And of course, assessment for silent cerebral infarct with cognitive testing as needed. In addition to supporting the young adult in knowing about safe sex practices, in the case of the individual with sickle cell disease, it's important to know their partner's trait status. And again, to assess the ability to make future independent decisions as a young adult. Next slide. These medical milestones grow out of the prevalence of adult sickle cell comorbid conditions that start in childhood, including the relatively high prevalence of silent cerebral infarcts, bone disease, asthma, chronic sickle lung disease, and renal failure. Next slide. The milestones with regard to healthcare knowledge includes that the individual needs to understand what their diagnosis is and understand then what sorts of medical screening they need to have, as well as the potential for medication such as hydroxyurea that they should be offered. Next, the individual needs to know about their pain plan and to know how to apply preventive measures for sickle cell complications. The young adult should have knowledge of who their current primary healthcare team is and who their future team will be. In terms of their medical history and their medical summary, they should know what their medications are, what their allergies are, the most important components of their medical history. Next slide. And then this knowledge should translate into skills. So the youth should know how to implement the pain plan. They should be adherent with their medications and demonstrate the ability to address barriers to medication adherence. It's important for the young adult to articulate important components of their medical history and articulate strategies for informed reproductive decision-making. A skill is understanding health insurance status and knowledge of benefits and co-pays. And finally, the young adult should be able to address potential challenges to academic and vocational attainment along with their family. So they should be discussing with the provider missed days of school and work. They should have a 504 plan if that's needed. The school should be supportive of them with regard to fluid intake and bathroom breaks. And another important question is, how many friends know that you have sickle cell disease? And we found in our research that an affirmative answer of even one person knowing that you have sickle cell disease in the school setting can really be extremely important to reduce isolation. Next slide. The social milestones with regard to the parent or caregiver and their support of the young person in the medical system begin with the parent or caregiver starting to fade their involvement at medical visits. Next, from left to right, the parent begins to supervise, is supervising medications and the medical visits, but ultimately the medical visit with the provider is accomplished with the patient by themselves, and the provider should validate with the parent afterward what occurred and what the discussion was with the youth's permission after a certain age. Then the healthcare visit is conducted without the parent. The youth should visit their healthcare provider. It will be optimal prior to transition. And then finally, the youth is able to independently seek out and obtain acute and preventive medical care. Next slide. So a summary of these transition readiness is that the individual has the knowledge they need, the skills that they need, they have an attitude of positivity toward the transition process, and then they have confidence in their ability to do what they need to do to take care of themselves. And the attitude piece is important, and it has been touched on, I think, in the last webinar, that youth and adults have expressed hesitation about transition, and their families as well, but that relieving the unknown by visiting the place where the person would be transferred, and just, again, having a positive attitude of trust in the receiving adult provider, that sort of thing can really be helpful. Next slide. So in the area of self-efficacy, or again, confidence in one's ability to transfer into the adult world, in our multi-site study, we found that patients who had higher self-efficacy were more ready for transition. And it may be hard to read these questions, but they're questions that are on such things as, how sure are you that you can do something to cut down on most of the pain that you have when you have a pain episode? So again, it's about confidence or surety in dealing with the complications of sickle cell disease. Individuals with higher self-efficacy had decreased reports of stress and general support, and as I mentioned, having friends with whom the sickle cell diagnosis was shared was associated with better healthcare knowledge and skills. So again, transition includes not just knowledge and skills, but these attitudes and confidence in one's ability to transfer into the adult world. Next slide. But a challenge in the transition literature remains defining what is a successful transition. And I think that this is certainly a point of discussion. So a question might be, is the individual in the care of a competent health provider? Is the individual in an organized system of care? Is a youth or young adult competent to partner with their healthcare providers, or do they have supports in place to assist? Are they receiving preventive and condition-specific healthcare consistent with clinical guidelines and best practices? And are they well functioning and realizing their potential? So the actual definition of successful transition probably contains all of these elements, but further research is really needed to be able to definitively say, again, what constitutes a successful transition. Next slide. When a systematic review was done of research on what is a successful transition, this was done by Lynetta Jordan and her colleagues. When they did the review, they reviewed 14 articles, and they put forward 3 clinical recommendations that are based on limited evidence, with one being the highest level of evidence, and 3 being the lowest level of evidence. And then the strength of these recommendations as well are based on whether or not there's good quality patient-oriented research. And so the levels are A, B, and C, and the strengths of these recommendations are in the B area, again suggesting that there's more research that's definitely needed in transition and sickle cell disease. But the bottom line is that the research supported, or the review supported, that the transition plan needs to be flexible, and the patient does need to be at the center of that plan. Parents and family remain key supports for the youth and young adult. And finally, healthcare providers. There's a sore need for education of healthcare providers to make the transition seamless from pediatric to adult care. Next slide. So I want to wind up by talking about personalized transition and looping it back to the early discussion on ethics. The definition of autonomy needs to be what the family and youth says it is. So they may have different models of autonomy that differ from the provider's definition, and it may include shared authority, shared decision making. So providers must be sensitive to families and youth's models of where the young adult needs to be in their view, and there needs to be a partnership between the provider and family and young adult to personalize the transition process. The transition process needs to be tailored to, again, the young adults and families' defined goals and their values. And then finally, there needs to be a consideration of social and contextual aspects that could either diminish or enhance difficulties with transitioning youth. So I would want to leave you with the idea that transition does have to be a personalized process. Individuals with sickle cell disease are unique. I mean, we need a system of approaching transition, but in keeping the youth and family at the center of the process, then we respond optimally to their needs, their values, and their goals. Next slide. And so I'd like to thank you and move on to our next speaker.
Okay, thank you so much, Dr. Treadwell. Our next slide, please. And now it is my pleasure. Oh, and I'd like to introduce our next speaker, Dr. Amy Sobota. Dr. Sobota is a pediatric hematologist and health services researcher with an interest in improving care for children and adolescents with sickle cell disease. Dr. Sobota grew up in Wisconsin and went to college at Harvard. After graduation, she spent 3 years volunteering in Africa prior to returning home for medical school at the University of Wisconsin-Madison. Dr. Sobota completed her pediatric residency at Children's National Medical Center in D.C. and was selected as chief resident. She then moved to Boston and completed a fellowship at Children's Hospital in Boston and the Dana-Farber Cancer Institute, and received a a master's in public health from Harvard School of Public Health. In 2010, Dr. Sobota moved to Boston Medical Center, a safety net hospital with a mission for working with those underserved. She also directs the Sickle Cell Disease Transition Clinic at Boston Medical Center, which serves young adults aged 18 to 22 with sickle cell disease, preparing to transfer to adult care. Welcome, Dr. Sobota.
Thank you so much. I'm really happy to have a chance to talk to the group, and I know Dr. Treadwell and I are hoping to leave some time for questions and discussion at the end. So I wanted to wrap up what sounds like a really terrific series of webinars by talking a little bit about what we've learned from patients and what models may work or are promising, at least, in improving transition. Next slide. But before I get into that, I think it's worth repeating that transition and transfer are not the same thing. Unfortunately, sometimes these terms get used interchangeably. Next slide, please. But transition is really a process, and it needs to start very, very young The American Academy of Pediatrics recommends starting at age 12 or 13, but frankly, we should be starting, right from birth and from young childhood, preparing children and their parents for their eventual move towards independence. Next slide, please. Transfer is often a component of the transition process, and for a while I actually spoke about it as though transition then culminated in transfer. Next slide, please. Until I was corrected by an adult hematologist who said, no, transfer is just somewhere on the continuum of transition. Patients may transfer from pediatric to adult primary care, from pediatric to adult hematology, but once that transfer is made, the patient's needs don't just magically stop. Patients don't stop maturing, right? So a 22-year-old who has just joined an adult clinic, perhaps has just graduated from college, certainly doesn't necessarily have the life skills that a 40-year-old patient does. And so that transition process, or that process of becoming independent, really does need to continue until the young adult no longer needs those supports. Next slide, please. Or what transition is not. This does not mean you can't transition your patient to adult care when they become pregnant. You cannot transition your patient to adult care when you suddenly notice they're 18. Those are transfers, not transitions. And this is a cartoon thanks to Dr. Jack Maypole here at Boston Medical Center. This is what we do not want to do, nor do our internal medicine or adult hematology colleagues want us to do this approach. Next slide, please. So why does healthcare transition matter in sickle cell disease? And I'm just going to quickly show a little bit of data that many of you may have seen before. Next slide, please. And this slide shows, the dotted line shows the mortality rate for children with sickle cell disease. And you can see that that line goes down over time. Thanks to a lot of significant advances like penicillin prophylaxis, vaccinations, children with sickle cell disease are living longer and healthier than they ever have before. Unfortunately, what the solid line at the top shows is the mortality rate for adults, which hasn't mimicked that. So even though the life expectancy with sickle cell disease is getting older, patients are still dying unacceptably young. Next slide, please. And there was a seminal paper in 2010 that talked about this time post-transfer, or actually post-leaving pediatric care, as a very risky one for young adults. And so whatever it is that we've been doing, we haven't been doing enough. Next slide, please. So how can we bridge the gap? I think there's actually quite a bit of literature about the fears that adolescents have when they think ahead to leaving pediatrics. But around this time of year, as our kids are all going back to school, I think we're all familiar with that, right? So when my preschooler was moving on to kindergarten, he thought that was a terrible idea, right? Why should he leave his friends? Why should he leave his teachers who loved him? The kindergarten teacher couldn't possibly be as nice as his preschool teacher. Very similar to what a lot of pediatric patients think. But what I was interested in seeing is what happens to those patients after they've become enmeshed in the adult healthcare system, right? After a month, my little one was thrilled to be in kindergarten and proud to say he was too old for preschool. So how do we provide the support that young adults need while not being completely overwhelmed with the fears that adolescents described? So we held some focus groups with young adults who had transferred to adult care within the previous 5 years. And I just want to share some of those quotes because I think they illustrate themes that are echoed in the literature, and then share a little bit about some of our programs and programs in other places that really address those needs. Next slide, please. So some of the major themes in the transition experience, unsurprisingly, were the familiarity with providers and with facilities. Young adults have often been going to the same doctor, the same hospital for 18, 19, 20 years. Changing is scary. Change is scary. There were concerns about the attitude of adult providers, adult nurses, especially significant mistrust of patient-reported pain. And then a lot of concerns about the lack of knowledge of sickle cell disease. Both the patients themselves felt they didn't have enough information and that providers didn't. Next slide, please. So one of the things that really came up vividly in these focus groups was the difference between pediatric and adult providers. I was talking about how it catches you off guard going from pediatrics where you're coddled, and then saying, you can't be a baby all your life, you got to grow up and deal with it. And I think this is true, but I think this is something that we as healthcare providers don't explicitly talk to our patients about. Next slide. And I don't want to get us off the hook by just saying, oh, fine, the culture is different. That is an issue that maybe we should be addressing. But right now, the pediatric and adult healthcare cultures are different. And I don't think that's a bad thing, right? Just like my elementary school kid isn't having the teacher take him to the bathroom anymore the way he did in preschool. As people grow older, they need different things from their physicians. And I think talking about the move to adult care as part of the process of gaining autonomy and gaining independence is a really positive one. But if we don't prepare patients for that difference, right, they're going to be calling you. They're not going to be calling your mom. The pharmacy is going to expect you to call for refills, not your mom. You're going to need to ask them for what you need. People aren't going to be necessarily coming in and offering it. If we don't prepare patients for that, then it's no wonder that they stumble and have trouble succeeding. Next slide, please. We heard a lot of concerns about the understanding of sickle cell disease and pain. And to my chagrin, this is at our institution, which is a Sickle Cell Center of Excellence, and I was fairly horrified to hear some of the comments that members of our focus group said about feeling like they needed to give a sickle cell education class in the middle of a crisis, or that people doubt them when they're here for pain. And maybe the most poignant quote from this group, unfortunately this is nothing new to the people listening, but somebody said, "I'm here to get help. If I wanted drugs, the hood is down the street." And trust me, at the corner right outside Boston Medical Center, Albany and Mass Ave, you can buy anything you need. And trust me, the wait is a lot shorter than in the adult emergency room. So patients really are seeking our help. And I think it's incumbent upon those of us who work with sickle cell disease all the time to make sure that we share that knowledge with folks who only see this intermittently. Next slide. So some of the things that we've done here, we realized that for a lot of the trainees at an academic medical institution, their only exposure to individuals with sickle cell disease is while they're admitted to the hospital. So their entire mental image of sickle cell are people who are on a PCA, on opioids, not acting like themselves and in pain. So I now have the pediatric intern shadow me in pediatric hematology clinic once during their rotation at Boston Medical Center. And so they're able to see, last week they saw a young woman with me who was here for her final visit before going off to college. They can see the little kids who are there for their hydroxyurea checks. They can hear some of the anticipatory guidance we see, but I think more importantly, they can replace that mental image of sickle cell disease with a healthy, thriving child or young adult who's living their life and just coming in for a routine visit. We've done a series of lectures with the internal medicine residents, with nursing staff, and with ED providers. And I'm excited this year for a new initiative. We were just asked to participate in a series of health equity rounds talking about discrimination and unconscious bias in medicine. And so we're going to use some sickle cell cases to illustrate that. The picture on the left is of an incredibly powerful video that Sophie Lanscron and her colleagues at Hopkins have created. And if anybody hasn't seen this, I really urge you to. I think these slides are going to be available, or you can Google it. But it is an incredibly poignant video of several individuals in Baltimore living with sickle cell disease talking about their experiences in the emergency rooms. This is a video that I've now shared with the chief residents of all of the different services at Boston Medical Center. We're going to highlight it in the health equity rounds, and I think this, more than anything else, drives home what we as providers need to do to educate ourselves about the population. Next slide. We also need to make sure that we're educating hematologists, right? A lot of adult hematologists don't go into hemonc to treat sickle cell disease. They go into it because they want to cure cancer. There's nothing wrong with that. But then when they're seeing patients with sickle cell disease, they may not be as familiar. And so I was really excited that the American Society of Hematology is featuring an article about transition for patients with hemoglobinopathies. They interviewed me, they interviewed a lot of other people with expertise in this area, and it's available online. But I think making sure that we're providing education at all levels to everyone who's going to be involved with these patients is crucially important, and hopefully will change that experience that patients have, unfortunately, sometimes in adult care. Next slide, please. So it was also interesting when we talked to the folks in the focus group about taking responsibility for their disease. And this came up several times. There's a rough patch at first. You sort of get drop off. The first quote, the guy went on and said, you have to have that really inconvenient talk with your doctor about why you're not taking your medication. But then you get back on track. Then you get yourself scheduled. Then you get used to it. And I think to me, this was really eye-opening, that often we bemoan the fact that, oh, they didn't show to their first adult clinic visit. Oh, they're no longer taking their hydroxyurea. But young adults may need a little bit more support, right? We all know that the time of transition and transfer happens when there's a lot of other moving parts in people's lives. Next slide, please. And so I think extending support into the adult clinic is a crucial step. One of the things that I've started doing here is we have patients come back to pediatric hematology after their first adult visit. And I think just knowing that they can come back and talk to us is really reassuring. We troubleshoot how did things go. We do run a transition clinic here, so most of them know where the adult clinic is, but even that can be a stumbling block. But I think knowing that there's going to be that dialogue is reassuring for patients. And if they're having trouble, they can sort of bop back and forth a little bit, and that's okay with me. Some places I know have a transition coordinator who continues support until the young adult is ready to be independent. And I actually personally think this is a lovely model. This provides some continuity between the pediatric and adult worlds. And again, like Dr. Treadwell was saying, it provides a very patient-centered approach to transition because everybody isn't going to need the same support or the same length of support. Next slide, please. Well, and then as Dr. Treadwell also said, we really struggle with how to define success. And this quote is great. I had to clean up his language a little bit. The original was actually probably much more apropos, but not appropriate. How do you find success? You're doing what you're supposed to be doing and your mom doesn't have to bug you about it. That's a little bit hard to measure, but it really is true. That self-management and that self-advocacy is so crucial in transition. Next slide, please. I know there's several different instruments out there. Dr. Treadwell had showed the one she uses. This is another option. It's a non-disease specific transition readiness assessment questionnaire. The answer choices are based off the stages of change. You can Google Track 5.0 and find it. And so what you would expect to see over time is patients' comfort and familiarity with various aspects of managing their disease, managing their life, and advocating for themselves to increase. This is also a lovely way to provide some individual counseling. Maybe somebody's great at managing their prescriptions, but really nervous at talking to the doctor. And so that's something that you can focus on with that individual patient. I think this also emphasizes to us, at least here, we start doing this at age 13, the need to start young, right? You can't expect a patient at 18 to all of a sudden be able to give their full medical history. But what we can expect is starting very, very early, a kid to tell you why they're seeing a hematologist. Maybe at 10 or 12, they can name their medications or tell you what they do at least. And so having those little steps along the way, I think makes the whole idea of a final transfer a little bit less overwhelming. So I just urge people to think about what works best for your population and what works best in your sort of medical record system, but some way of looking at self-management and self-advocacy on an individual patient basis. Next slide, please. And then finally, looking back, what did people like? It was interesting to me, since I run our transition clinic, how many people talked about how annoyed they were at the time, but looking back, they appreciated what they learned in transition clinic. Somebody actually even said it should be mandatory, and I felt like saying, I don't have that much power, but yes, that would be great. And this concern about change. So I think a lot of times it's easy to sort of give up and say, you know, we don't have great show rates, people aren't coming, but folks do want the information. They just may not want it in the way we're giving it as healthcare providers. Next slide, please. So one of the things that we've done here, and I know other places are doing similar things, is we have a guidebook. It's available online. Please feel free to use it, download it, share it. It's very BMC and Boston specific, but it provides some education about sickle cell disease. It provides contact information for both pediatric and adult clinic, has a little cheat sheet on who to call for what, right? Because we have patients calling the social worker when they're having pain. And so this is something that folks can maybe look at and use in their own time. You know, I would love to have more of an app or mobile technology, but again, trying to meet the patient's need for information, but not necessarily in the traditional sense of you have to come to clinic. Next slide, please. And so just a little bit of summary of some of the recommendations. I think we need to normalize the transition process. We in pediatrics need to watch what our language is. We don't want to say things like you have to leave. We want to make sure that this is a normal part of growing up and becoming independent. Prepare young adults for the changing culture in the medical system. Educate providers about sickle cell disease. I think you've heard this from all of us. And then really promote self-management and self-advocacy among young adults starting in adolescence or even sooner. Next slide, please. And again, I thank you for this opportunity to talk, and we're happy at the end to have questions. My email is on there if anybody wants to be in touch with me directly. Thank you again.
Thank you, Dr. Svoboda. Both very, very powerful presentations. I know that Dr. Treadwell actually had a couple of additional slides, and given the time that we have left, I'm going to have those appear now. Dr. Treadwell, do you want to pick up where we left off? Dr. Treadwell?
Oh, yeah. Okay, I think I'm unmuted now. Can you hear me?
Yes, we can hear you.
All right.
Sorry about that.
Okay. Okay. So at this point in the webinar, I had offered to bring on a young adult and or family member who had recently transitioned to give their story. And the good news is that I approached 3 different people, but school just started this week, so they're taking their college classes. And for another person, she's working and just couldn't get the time off. But interestingly, I also got a call from a parent, and wanted to go ahead and share with the family's permission a story that I just learned this week as well. So this is Jacob, who has sickle cell disease, SS disease, and he was followed in the Bay Area. There are about 4, I think, sickle cell special care centers, and so he was followed at one of those until the age of 21. But there is only one adult sickle cell special care center in the Bay Area, and that's over here in Oakland, and the family does not live near that center. They don't live near us, but they have to come to us. Now, a couple weeks ago, Jacob started having some abdominal pain, and his physician did request an MRI. But there's a change in insurance in California from what's called California Children's Services to what's called Genetically Handicapped Persons Program. And the adult insurance is notoriously slow, actually, for getting the referrals through. Jacob and his mother reported that they felt like he had received good care from his pediatric providers. They did feel transition was discussed, transfer was discussed, but once they got on the other side, they actually felt they weren't quite prepared for the process. Next slide. What's been going on, it seems, is that Jacob hasn't been communicating as well with his providers as his mother would have thought. So she worked with the providers and kind of really stepped back and let him communicate himself. But she realizes now that he has not been communicating as effectively as she would have hoped, or as he would have hoped. So he hasn't been saying, you know, I've been having a lot of pain. My school attendance has been irregular. In the last year, I've really only had 1 good month. So the mom, again, has gotten all the permission signed, and she's going to join Jacob in visits with his adult providers the next couple of times. And some other interesting questions that they brought up is, should the primary care provider actually be a hematologist rather than an internist trained in the hemoglobinopathies? And I did explain to the family that there are, you know, just very few adult hematologists out there, and this is a common model actually, but it was an interesting question to me that they asked. Secondly, they asked about being under the care of a hospitalist rather than being under the care of the primary provider. And I think this goes back to Amy's, what she talked about in terms of the culture of medicine, and that was talked about in the previous webinar, that this is actually not uncommon as well to be cared for by hospitalists in the adult world. And in the pediatric world, usually the sickle cell center is where the person is admitted, and you're going to see that continuity between your outpatient and inpatient providers. So they did expect, the family had been told about the changes in this way, but when they actually experienced it, it was a little bit upsetting. And then finally, the costs of care can never be underestimated. So insurance is one thing, but having to travel, you know, further away from your home to a setting, paying for parking, and so on when the care isn't located near your home, these are just the issues that that were brought up by this story. And I just wanted to bring it up to the group, not to say this this is a quote poor outcome or good outcome, but just to illustrate that this is how it goes, that it's a work in progress. Transition and the transfer should be considered a work in progress. And again, it's great that Dr. Sabota talked about when individuals go into the adult world, they come back after the first visit and just kind of talk about how it went and what their concerns are. I think that could go a long way to addressing some of these unknowns, but at the same time, some of these things occurred for this family over the course of the 3 years after they transferred. So, you know, you can't prepare people for everything, but what you do is you keep the lines of communication open, that kind of thing. So that's the story I wanted to share there.
Well, thank you very much. I really appreciate that sharing. And for those of you that are on the webinar, if you have questions, please go ahead and type them in. We don't have any questions as of yet. So Dr. Sabota, if I could just ask you if you have any additional comments on Jacob's story.
Sure, absolutely. I think that this is unfortunately all too common, and I think one of the things that I say, and I think this is the true for our kids too, is let's let people fail when they have a safety net under them. So, for example, in this story, I was struck by the mom saying, you know, she knew she needed to step back and let Jacob talk to the doctor, but it sounds like perhaps that hadn't been done or hadn't been done frequently when he was still in pediatric care. So one of the things that I think should be standard is, as Dr. Treadwell was saying earlier in her talk, starting in adolescence, have the parents step out for part of the visit, then maybe have them stay in the waiting room for part of the visit, then have the young adult come where there's still that familiar provider and that communication back and forth with mom. So let's make sure that we're giving young adults plenty of chances to practice this, right? Not just say, oh, sure, I can ask questions, but actually practice it. There's times, for example, that I put young adults on the phone when they've needed to schedule an appointment. They get through one or two questions, and then the person on the other end of the phone says, well, can you come on Thursday? And they cover the mouthpiece, look at me, and say, I have class on Thursday. What do I say? Like, well, you tell them you have class on Thursday. But until you've actually done something or actually experienced it, it's very, very difficult to know how prepared you'll be and in what ways you need that support. So I'd say lots and lots and lots of opportunities for young adults to practice this growing bits of independence before they get transferred to a new provider.
Yeah, we do have a question, and this is for either Dr. Treadwell or Dr. Sabota. Anecdotally, I see significant numbers of adolescent young adult patients who seem to have cognitive or affective disorders that interfere with their ability to absorb transition education. Are there any data to support or quantify this?
All right, this is Marcia. That's an excellent question. There is a lot of, obviously, attention paid to, silent cerebral infarcts and the impact on educational attainment and life skills attainment. Specifically in relation to transition education, that's a really good question, and I'm not aware of, in fact, a study on this. I've seen more of an individualized, again, approach, as I was talking about, where you want to think about if the person has had a stroke or has silent cerebral infarcts or has a change in cognition, which may mean that they need to be evaluated even though they've been clear up to this point in time. And then certainly the mental health issues are extremely important. And again, I think the way people approach this is more on that individualized, personalized model, and that research in this area is really needed about this absorption of transition education. And I think we do understand that more from the anecdotal kind of standpoint. I don't know if you have anything to add, Amy.
No, unfortunately, I don't know of any good data either. I mean, it stands to reason. I think as people are trying to hopefully do more research in this area and doing transition readiness assessments and perhaps analyzing those based on young adults' underlying cognitive issues, that may become more relevant. I do think one thing that I would say is interesting is also trying to think about other partnerships. So, for example, one of the suggestions that had come up on another webinar I was on was looking at something called vocational rehab. Lots of states in their Department of Public Health or Department of Mental Health have services for young adults with known cognitive disabilities who are going to be outgrowing the pediatric supports or programs in their states. And I haven't sort of pursued this, but it's an interesting idea. Are there partnerships like that where there's existing resources that aren't specifically for our sickle cell patients but might apply that we could leverage if there's people with expertise in that particular patient population?
Yes, and we do have another question. There's a lack of adult providers for sickle cell disease, and even fewer who are really tied into sickle cell disease care. This is common in cities, but imagine the problem in rural areas. How to interest primary adult care docs who don't know sickle cell disease to their care?
Oh my gosh. Sorry, this is Amy. So I'm sort of waving my hands in the air in my own office. I will start briefly and then let Marcia speak. So I would even take a step back. There are adult hematology oncology doctors who don't have an interest in sickle cell disease. And that's where I think we need to start. If you're doing a hem-onc fellowship at the moment under adult, a lot of places it's optional whether you do sickle cell rotations. A lot of places it's optional if you see sickle cell patients as an outpatient. Personally, I think that adult hem-onc fellowships need to mandate exposure and expertise with sickle cell patients and have all adult hematologist oncologists see those patients. I shouldn't have to call an adult hem-onc practice and ask if there's somebody there who will take somebody with sickle cell disease. And then in terms of trying to get primary care doctors involved, one of the things that I've heard in terms of other transition is why don't we do something with student loan debt? Right? Why don't we think of it like people who go out to the Indian Health Service? If you're in an underserved area or if you're taking care of an underserved population, there's student loan forgiveness. I think there need to be creative ways to make this attractive, because the reality is if one primary care doctor has 6 or 10 patients with sickle cell disease in their panel, it's going to be difficult to get them engaged. And Marcia, do you have other ideas?
Yeah. As mentioned at the beginning of the webinar, we're one of 4 grantees with HRSA that is looking at improving networks of care, and HRSA's mission, of course, is to improve access to care. And so transition in sickle cell disease is sort of at the center of some of these issues with HRSA. And given that, there's a whole aspect that has to do with reimbursement for providers. So if you remember in the American Academy of Pediatrics, you know, they're saying, see the person as much as you need to until they have demonstrated these skills and this knowledge. In the adult world, when we've actually talked to primary care providers, they let us know, well, that's an impossible thing to ask us to do. We can't do that in the current climate of reimbursement. So I think that that's a whole nother level of policy that needs to be addressed to understand that our very complex patients with sickle cell disease do need sometimes more intensive care and more visits than would be normally provided. And in fact, again, we have talked to our insurers here in our area to educate them on that point. And that's another work in progress to really get reimbursement. But that's a whole nother level of things that I think that we all have to, again, educate policymakers and so on about this issue.
Okay, we do have a couple other questions coming in. To complement readiness assessments, how can we objectively evaluate the success of transition 6 to 12 months after the transfer?
Well, again, in studies that I know that are ongoing, people have taken a surrogate marker that is that the individual has made and kept 2 outpatient appointments. So that's the sort of objective measure of transition, quote, success. But I do think there are patient-reported outcomes that we could use as well now that are validated and reliable. And so patient-reported outcomes on pain episodes, as well as quality of care. I think we can introduce those.
Another question, how is transition care an independent variable in the mature realization of the experience of health disparity or medical stigma, assuming one's quality of care can't easily be improved?
I think that's an excellent question and a really excellent point. And I think, you know, for example, the video that I referenced, sorry, this is Amy, the video I referenced in my talk goes on to talk about this. You know, unfortunately, we do know that there are significant racial and ethnic disparities in both in healthcare in general, but in the treatment of pain, for example. And so one of the aspects of transition, I think, needs to be some self-advocacy, things like having a portable medical summary. Now with patient portals, can we leverage patient portals? So when somebody goes to an unfamiliar hospital, it's no longer a young Black man walking in and saying, I need 6 milligrams of Dilaudid. It's somebody who says, here, let me pull up my patient portal where it gives my care plan. Or here, this is my summary from my hematologist with what my complications are. So trying to figure out ways, and I'm not sure if that's getting to what you were talking about, Bill, but I think that I do wish we could wholeheartedly change the system immediately, since that isn't going to be able to happen right away. Having patients do self-advocacy, maybe have somebody go along with them to the hospital who can advocate for them if they've received opioids and then have more trouble thinking clearly. I think there are steps like that that we can, unfortunately, need to maybe encourage patients to take.
And then maybe our last question, as a patient advocate for those with sickle cell disease, what approaches should one take to start a conversation with families and pediatric teams about transitioning into adult care?
Okay, so this is Marcia, and I would go back to what Amy said, and we practice this as well, and that is that the idea of transition, the idea of transfer to adult care needs to be normalized really from the beginning. And the family given the expectation, your child is going to live for a long time. We want that life to be a quality life. We want this child to be fully functional and contributing to society, and they have something of value to give to this world. And so when you start at birth with the expectation that the individual is in a phase of their life right now where they are in pediatric care, but one day they will move into adult care, I think that's the conversation. So early, often, and I noticed that you did put pediatric team in the question, and I think that that's a good point as well, that again, it's the pediatrician who as well should be, or pediatric hematologist talking in this way with the family, but you certainly can as well as a patient advocate.
Okay, well, thank you all so much. This has really been a great conversation. And in conclusion, I just want to thank our speakers for their wonderful presentations and sharing both their expertise and experience with us to gain a better understanding of the complexities of transitioning from pediatric to adult care with sickle cell disease. It is clear that much has been done and there is growing understanding of what good transition is. However, we have a long way to go as well, thus improving the quality of life and the health outcomes for those living with sickle cell disease and their families. I also want to thank all who joined us today for their interest and commitment to the cause, as well as their thoughtful questions and comments. Please feel free to contact me for any further information or contact info related to the webinar or any other topic of interest. We have recorded this session today, and we will make it available to all as soon as possible. We will also circulate a very brief survey, 6 to 7 questions, that we ask you all to take a moment to complete. It's a great tool as we move this series forward. Again, thanks so much for being a part of today's webinar. We look forward to staying connected with you all and continuing in our commitment to the entire sickle cell community. And I'm just going to add a little note, just that this was our, session was one of our, we had the most number of RSVPs that we've ever had before. The growth of this series and the growth in the interest in it has really been profound for myself and our organization. I just want to point out that we have been asked to have our recordings of these webinars. They're now being posted on national sickle cell disease websites, as well as the American Academy of Pediatrics. And so we are just incredibly grateful for this, and we are really committed to continuing to talk about really important topics to this community. So if anyone that is still with us today, if you have ideas or thoughts on things that we should be looking at and discussing as we move this series forward, I would love to hear from you. I do believe that the two presenters are willing to share their slides. Again, the recording will be, I'll send a link to everybody as soon as that's up, but you can just communicate with me directly via email. And again, thank you very much for joining us today. And that's it for now. Good day.